So, good morning, ma'am. This is the continue of the one the one that I performed yesterday po sa thorax po, ma'am. Okay po, ma'am. Proceed na po ako sa palpate for tenderness and sensation. Normally, no tenderness, pain, or unusual sensation. Abnormally palpated as tenderness causes by COPD or muscle sensation or muscle soreness. Next po, ma'am, palpate for crepitus. Abnormally, no palpable crepitus. Abnormally, crepitus can be palpated in subcutaneous tissue areas of extreme congestions or consolidations. Next po, palpate the surface of characteristics. Skin and subcutaneous tissue are free of lesions and masses. Abnormally, physician should evaluate any unusual palpable masses. Next, palpate for fremitus. Normally fremitus is symmetric and easily identified in the upper regions of the lungs. Abnormally, unequal fremitus caused by results of consolidation, increased fremitus, bronchial obstruction, air trapping, in emphysema or pleural effusion. Also, lastly, the diminished fremitus even with a loud spoken voice is the obstruction of the tracheobronchial tree. Next, assess for expansion, chest expansion. Normally, deep breath, examiner's thumb should move 5 to 10 cm apart symmetrically and pressing together a small skin old. Abnormally, unequal chest expansion can occur with severe atelectasis. Lastly, the decreased chest exertion at the base of the lung causes COPD. Let's proceed to the auscultation. Percuss for tone. Normally, resonance elicits over the normal lung tissue. The percussion is the elicits of flat tones over the scapula. Abnormally, hyperresonance elicits indicates to trap air such as emphysema or pneumothorax. Percuss for diaphragmatic exertion. Normally, good exertion is the 7 to 8 centimeter. Abnormally, diaphragmatic descent may be limited by atelectasis of the lower lobes. The lower lobes or by emphysema in which diaphragmatic movement and air trapping are minimal. Other possible causes for limited descent is the pain or abdominal hollow quality and loud amplitude. Next is the bronchovesicular causes moderate pitch, mixed quality and moderate amplitude and same duration. Next is the vesicular, is the low pitch, breezy quality, so amplitude and long duration. Abnormally, diminished or absent sound is a little or no air is moving in or out of the lung are being auscultated. Increased breath sound occur when fracture when consolidation or compression results in a denser lung area that enhance the transmission of sounds. Auscultate for adventitious sounds. Normally no adventitious sounds such as crackles, or whiz and continuous are auscultated. Abnormally, discontinuous sounds are the crackles fine, crackles coarse, continuous sounds, pleural friction rub, whiz civilian, whiz soronus. Next, auscultate for voice sounds, bronchophony, egophony, and whisper pectorology. Normally, the voice transmission is the soft, muffled, and but the letter E should be distinguished. Also, the transmission of the sound is very faint and muffled. Abnormally, sounds is transmitted clearly and distinctly in such areas of the sounds as if the client is whispering directly to the stethoscope. Okay, let's proceed to palpation. Palpate for tenderness, sensation, and surface masses. Normally, no tenderness or pain is palpated over the lung area with respiration. Abnormally, tenderness over the thoracic muscle can result from exercising, especially in a previously sedentary client. Next, palpate for tenderness at costochondrial junction of the ribs. Normally, palpation does not elicit tenderness. Abnormally, tenderness or pain at the costochondrial junction of the ribs is seen with fractures, especially in older clients with osteoporosis. Next, palpate for crepitus, like the posterior thorax. Normally, no crepitus is palpated. Abnormally, crepitus may be palpated in extreme congestion of consolidation, particularly in client with lung disease. Next, palpate for any surface masses or lesions. Normally, no unusual surface or masses or lesions are palpated. Abnormally, surface or masses lesions may indicate cysts or tumors. Next, palpate for primitus. Normally, a decreased intensity of a primitus is expected toward the base of the lungs. Abnormally, diminished vibration even with a loud spoken voice causes obstruction of the tracheobronchial tree. Next, palpate the anterior chest expansion. Normally, thumb move outward in a symmetric. Abnormally, unequal chest expansion. Next is, we'll be going to percuss, the percuss for tone. Okay, let's proceed. Percuss is a piece above the clavicles. Normally, resonance is the percussion tone elicit over normal lung tissue. Percussion, dullness over the breast tissue, the heart, and the liver. Tympani is detected over the stomach. Flatness is detected over the muscle and the bones. Abnormally, hyperresonance is elicited in such cases of trapped air such as in emphysema or pneumothorax. Dullness is characterized areas increase density such as consolidation, pleural effusion, or tumor. Next, let's proceed to Auscultation again. Auscultation for anterior breath sounds, adventitious sound, and voice. Normally, voice transmission is soft, muffled, and distinct. Uh, Voice transmissions will be soft, muffled with the letter E, should be distinguishable. Transmission of sound is very faint and muffled. Nor abnormally refer to adventitious breath sounds. Discontinuous sounds is the crackles fine and the crackles coarse. Continuous sounds is the pleural friction rub, sibilant, surulose. Next, auscultate from the apice of the lung straightly above the clavicle to the base of the lung at the sixth rib. As far as I know, there is no abnormal findings on the auscultate from the apice of the lung slightly above the clavicle to the base of the lung at the sixth rib. But there is the abnormality. The abnormality is the words are easily understood and louder over increased density, may indicate consolidation from pneumonia, atelectasis, or tumor. Inspect for anterior thorax. Inspect for the shape and configuration. Normally, the anterior posterior diameter is less than the transverse diameter. The ratio of the anterior posterior diameter to the transverse diameter is 12/2. Abnormally, anterior posterior equals transverse diameter is resulting in barrel chest and often seen in emphysema. Inspection position of the sternum. Sternum is positioned at the midline and straight. Normally, pectus excavatum is markedly sunken sternum and adjacent cartilage. Also, the pectus carinatum is the forward protrusion of the sternum, causing the adjacent ribs to slope backwards. Next, watch for sternal retractions. Normally, retractions not observed. Abnormally, sternal retractions are noted with severely labored breathing. Inspect slope of the ribs. Normally, ribs slope downward with symmetric intercostal space. Costal angle is within 90 degrees. Abnormally, barrel chest is configuration result in more horizontal position of the ribs and costal angle of more than 90 degrees. Observe quality and pattern of respiration. Normal is 12/20 BPM. Normally, respirations are relaxed, effortless, and quiet. They are of a regular rhythm and normal depth at a rate of 10 to 20 per minute in adult. Abnormally, takipnya, madipnya, hyperventilation, plasmol, hypoventilation, kinestroke respiration, violent respirations, ataxic, air trapping. Next is the inspect intercostal space. Normally, no retractions or bulging of intercostal space are noted. Abnormally, retraction of the intercostal space, increased respiratory effort, Next is the bulging of the intercostal space, indicates trapped air such as in emphysema or asthma. Observe for use of accessory muscles. Normally, use of accessory muscles is not seen with normally respiratory effort. Abnormally, neck muscles, sternomastoid, scleni, and trapezius are used facilitate inspiration in causes of acute or chronic airway obstruction or atelectasis.